The broadcast is now starting. All attendees are in listen-only mode. Unmuted.
So I want to thank people for joining us today. We're waiting a few more minutes to allow people to continue to join in. But I want to thank you all for coming to join our conversation about covering all kids, the path forward. Give it one more minute. All right, I think we'll start. So thank you all for joining today's congressional briefing, covering all children, the path forward. I'd like to thank our funders, the Robert Wood Johnson Foundation and the David and Lucille Packard Foundation for making this possible. I'd also like to thank Congresswoman Kathy Castor for sponsoring this briefing. We are here today to discuss solutions to a solvable problem. At First Focus on Children, we have a long and active history in fighting for healthcare coverage for all children. And this has been an issue that over the last 2 decades, we've made great progress in cutting the uninsured rate. So when the Children's Health Insurance Program was passed, and Kelly's going to talk more about this, the uninsured rate in our country stood at about 15%. So about 1 in 6 kids in this country did not have health insurance. And over the course of the next 20 years, we dramatically cut the uninsured rate for kids to less than 5%. So in a classroom of, 25 people, there'd only be, one to two that would not have health insurance. So we've made enormous progress toward that goal. In the last 4 years, however, we've reversed course, and the uninsured rate has begun to tick back up. So what we wanted to do is have a conversation about, we are so close to getting to the finish line. And so what do we need to do to get back on track to making sure that we get all kids in our nation covered with health insurance? I'd like to point out a couple of polling highlights. We did a poll last year with Lake Research, and they asked a few questions about how important it is to ensure every child in the U.S. has health insurance coverage. And as you can see, a very wide margin of people in this country, both, and it's Democrats, Republicans, and independents, felt very strongly that it is an important priority of our nation to ensure that all children have health insurance coverage. In addition, we asked a question about the Children's Health Insurance Program. That program has, again, has made a huge impact on cutting the uninsured rate in our country. And we asked people, 24 years later, isn't it about time that we make that program permanent? It has been proven successful. It is the only federal health insurance program that is temporary and has to be reauthorized all the time. And so we basically, as you can see here, the support also was very strong across the board for making sure that CHIP is permanent. Nearly 4.3 million children are still uninsured in this country. Most of those children are low income, and many of those children are children of color. In the richest country in the world, the number of children without health insurance rose in 2020 for the fourth year in a row. And it goes without saying that COVID has exacerbated this problem, exposing the inequities in our country. Today, we have assembled a terrific panel of experts to talk about the path forward. On a positive note, the President has proposed and Congress is considering several important improvements for children's health insurance coverage. For example, making CHIP permanent, no longer waiting for constant reauthorizations, requiring states to offer 12-month continuous eligibility for children in CHIP and Medicaid, stopping children from being dropped off the rolls, and enhancing premiums for people to purchase coverage through the ACA, and also covering adults through Medicaid for in those states that have not expanded Medicaid through the Affordable Care Act. First Focus on Children is committed to doing all that we can to see that all children have access to health coverage. We are a great country and we have the resources to ensure that all children receive health care. We just need the political will to do so. Last week during the First Focus annual budget briefing, Secretary Becerra said, our budgets are statements of our values. So is public policy. So what is the path forward to getting to all kids covered? That's what our speakers are here today to discuss with us. We have 4 fantastic speakers who are experts on children's health coverage. 3 of our speakers are pediatricians, so they bring unique insights about what is needed so that all children have a chance at a healthy start in life. Our speakers can also share with us some of the barriers that uninsured children and their parents face, both in finding coverage and staying on it once they enroll. Over the next hour, we'll explore federal policy solutions that can close the gap for uninsured children. We want this to be a conversation, so after our speakers are done, we will devote the rest of the time to Q&A. A bit of housekeeping, please drop your questions for our speakers into the chat while they speak, and we'll do our best to answer your questions during the Q&A part of our webinar. Before we turn to our speakers, we have a special welcome message from our congressional sponsor for today's briefing. Congresswoman Castor is an outstanding advocate for our nation's children. She's the founder and co-chair of the Congressional Children's Healthcare Caucus. Thank you, Congresswoman Castor. Thank you, Congresswoman. We really appreciate you hosting this briefing today. So now let me introduce our outstanding panelists. So I will just do a brief introduction of all of you, and if you want to say a few more words when it goes to you, please do so. Our first panelist is Kelly Whitener, and she's an associate professor of the practice at Georgetown University's McCourt School of Public Policy's Center for Children and Families. She's an outstanding partner and terrific expert on the issues of Medicaid and CHIP. She is also a well-known healthcare policy advocate for children, and we are pleased to have her with us today. Dr. Glenn Flores is a professor and chair of pediatrics, senior associate dean of child health, and the George E. Batchelor Endowed Chair in Child Health at the University of Miami Miller School of Medicine and physician-in-chief at Holtz Children's Hospital. At Holtz Children's Hospital, I'm sorry. I will also note that Dr. Flores is a board member at First Focus on Children, and we appreciate him for all he does in leading our organization. We also have Dr. David Rubin, and he's a pediatrician and director of the Policy Lab and the director of Population Health at Children's Hospital of Philadelphia. Dr. Rubin is an outstanding thought leader in children's health, and we are so pleased to have him with us today. And our fourth, but not last but not least, awesome panelist is Dr. Marcy White. She's the Chief Medical Officer at Total Healthcare, Inc., a federally qualified health center with 8 health centers in Greater Baltimore, Maryland. She's a board-certified pediatrician with over 13 years of direct clinical patient care experience and over 10 years in healthcare administration. So, and we also thank Dr. White for being with us today. So let's get started. And with Kelly, welcome, and we look forward to your comments. And I'm sorry that we had technical problems with Kelly's camera, but we can hear her, and she has, and she'll be speaking from slides, so we'll also be seeing those. So thank you, Kelly, for joining us today. We really appreciate you being here.
Thank you for having me, and I apologize for the technology difficulties. You'll have to take my word for it when I tell you that I stepped up my work from home look today and put on a jacket for you all instead of my usual hoodie. So we can pull up my slides and we'll get started. The Georgetown University Center for Children and Families is a nonpartisan policy and research center at the McCourt School of Public Policy. And today I'll be focusing on children's coverage trends in recent years, and I'll also highlight some strategies to reach all children with affordable, comprehensive health coverage. So first, looking at the trends from 2008 to 2019, you can see, as Bruce mentioned, that children's uninsured rates went in the wrong direction in the period of 2016 to 2019 after years of steady progress. And this increase of 1 percentage point from 4.7% to 5.7% may not sound like a lot, but it translates to about 726,000 more children without health insurance over that time period. And I'll also make a note before we go on about 2020. We rely on the US Census Bureau's American Community Survey to produce national and state-by-state estimates of the number of children without health insurance. But unfortunately, the Census Bureau was unable to produce ACS estimates for 2020 due to a low and skewed response rate when the survey was fielded early in the COVID-19 pandemic. So therefore, we won't have more recent estimates until the fall of 2022, when the 2021 data are hopefully valid enough to be released. Next slide. Children's uninsured rates vary by a number of different factors, including state residency, income, age, citizenship status, race and ethnicity, and more. And here you can see the wide variation in the uninsured rates by state, ranging from just 1.5% uninsured in Massachusetts to 12.7% uninsured in Texas. Next slide. Here you can also see how the uninsured rate varies by race and ethnicity. American Indian, Alaska Native, and Latino children are the most likely to be uninsured, with uninsured rates of 13.8% and 9.2% respectively. And I'll note that Latino here from the Census Bureau data refers to a person's ethnicity, and Latino children may be of any race. Next slide. The picture looks a little more alarming if you account for children who are uninsured for all or part of the year. And for families with low to moderate incomes, frequent income fluctuations from changes in work hours or shifts, seasonal work, and things like that can mean that children lose Medicaid or CHIP coverage, and this is a problem known as churn. Here you can see that non-Latino Black children and Latino children are the most likely to be uninsured or experience a gap in coverage during the course of the year, with rates of 11.7% and 13.9% respectively. Next slide. The Urban Institute produces an annual report that shows Medicaid and CHIP participation rates, or the share of eligible children who enroll, and key characteristics of the remaining uninsured population. This is a report that I always look for every summer and save to my desktop as soon as it comes out. As you can see, over half of uninsured children are eligible for Medicaid and CHIP today, but unenrolled, while nearly a third are ineligible for Medicaid or CHIP because of income requirements. Less than 10% are ineligible for Medicaid or CHIP due to immigration requirements or immigration and income requirements combined. These data can help direct the solutions to covering all children. Next slide. We believe that to cover all children, we must rethink our approach and establish a coverage continuum, checking in at key intervals in a child's life to make sure they are covered. This begins with birth. No child should leave the hospital without coverage. And from there, we believe that multi-year continuous coverage, that is allowing a newborn once enrolled in Medicaid or CHIP to stay enrolled until kindergarten entry, would help reduce churn and increase the share of children who enter school healthy and ready to learn. Finally, we believe that close connections between health coverage programs and schools would make sure that children and youth stay covered. For example, by checking insurance status at the beginning of every school year and facilitating enrollment in Medicaid, CHIP, or marketplace coverage as applicable. Next slide. Here we'll take a little closer look at getting into some of the solutions. So to reach the eligible but unenrolled population that I mentioned earlier, Congress could require 12 months continuous eligibility in Medicaid or CHIP and allow states to test multi-year continuous coverage that I just spoke about, for example, for children ages 0 to 5. States have the option to provide 12-month continuous eligibility today, and about half of states do. But in states without 12-month continuous eligibility, kids may lose coverage mid-year due to periodic data checks, missed notices, difficulty keeping up with paperwork burdens, and temporary income fluctuations. These gaps in coverage are harmful, and children with gaps in coverage are more likely to miss preventive visits and important prescriptions. The gaps in coverage also disproportionately impact children of color, as we learned on the earlier slide, including especially Black children and Latino children. Making it easier for children to stay covered would help narrow these inequities. It would also help if we were to make CHIP funding permanent, as Bruce spoke about earlier, so that states and families know that they can rely on it, and to eliminate premiums in CHIP. Even seemingly small premium amounts can prevent a family from enrolling or lead to a gap in coverage due to missed premium payments. I'll also note that 4 states also charge premiums in Medicaid, which federal law allows above 150% of poverty, and eliminating these premiums would be a critical step too. To help with some of the other pie pieces, Congress could establish a national floor for Medicaid and CHIP eligibility. The current median is 255% of poverty nationwide, but some states limit CHIP to less than 200% of poverty. And it would be helpful to remove restrictions related to citizenship status. I'll note that the vast majority of children in the US are citizens, including 95% of Latino children, but non-citizen children and children living in mixed status families are disproportionately likely to be uninsured. 5% of citizen children with citizen parents are uninsured, compared to 9% of citizen children with a non-citizen parent, 21% of lawfully present immigrant children, and 35% of undocumented children. Therefore, even though the overall share of uninsured children who are uninsured due to immigration restrictions is small, it is an important group to focus on when trying to reach all kids with health coverage. Next slide. Focusing now on the roughly 1/3 of uninsured children who are ineligible for Medicaid or CHIP because of the income requirements, plus some of the children who are ineligible because of immigration and income requirements, Congress could take a few key steps, such as improving marketplace affordability by fixing the family glitch. The family glitch is a complicated policy, but essentially individuals are not eligible for premium tax credits in the marketplace if they have access to quote unquote affordable employer-sponsored insurance. But the current definition of affordable only considers the cost of coverage for the employee and not for their dependents. Family coverage is often 3 times more expensive. This means that some families are ineligible for premium tax credits even though their ESI coverage is not truly affordable. The Treasury Department could fix the family glitch via regulations, or Congress could do so in statute by amending the definition of affordable to include the cost of family coverage. Fixing the family glitch would make sure that families are not being unfairly penalized when the full cost of family coverage is not being taken into consideration when determining eligibility for marketplace subsidies. And once again, I'll point that removing restrictions related to citizenship status, would also help reach more children with coverage. And just reemphasize that even though this is a small group in terms of raw numbers, it is a group that is disproportionately likely to be uninsured. And then finally, Congress could make permanent the enhanced marketplace subsidies authorized under the American Rescue Plan, as is currently contemplated in Build Back Better through 2025. Next slide. So finally, I think it's really important to focus on outreach and enrollment efforts. Families, particularly Latino families, benefit from application assistance in person or by phone greatly. And continuing to fund these programs and promote children's coverage at the national level will help reverse the negative coverage trends of the past few years when funding for navigators and other application assistance was cut significantly. It is also important for federal, state, and local government outreach and enrollment efforts to be done in collaboration with trusted community-based organizations to help reach those who are more likely to be uninsured. For example, citizen children living in mixed status families are almost 2 times more likely to be uninsured compared to citizen children with citizen parents. This could be due to parents' concerns about things like recent changes to public charge. Outreach efforts done in partnership with trusted community-based organizations are more likely to be successful in reaching these children by addressing those concerns that parents may have. Finally, I think it's important to go to where the children are. So focusing enrollment campaigns at schools, Indian health clinics, and family resource centers could also help reach children that are otherwise harder to reach and get covered. Next slide. Here's just a couple of links if you'd like to learn more about some of our work and some of our research. And I'll turn it back over to you. Thank you.
Thank you so much, Kelly. That was an outstanding overview of the issues and some of the answers we need to make toward getting us back on the path to coverage. And so thank you so much. Before we turn to Dr. Flores, we'll play a brief video clip about the Parent Mentor program that Dr. Flores worked on called Kids Help.
This program is very beneficial, not only for the community, but for the health professionals having to deal with unpaid medical bills.
Parent Mentor helped me by any questions that I had, concerns. I could call her day or night. She was a big help.
I enjoy doing it because I help others, teach them and show them that they can qualify if they send the right documents, and so long as they have an income and their child have Social Securities and they're born in the U.S., that they can qualify just because they're not.
I talked to a person like Valencia who has children who can explain to you, like, one time, my kid has gone through something similar to that. I don't know all the programs. I've worked for 40 years of my life, and I've never had to rely on a program. So did I know what to do? No, but she knew what to do.
I think it's a big difference when you have insurance. You don't have no problem being seen in and out, but when you don't have insurance, it's a big problem. She was always there guiding me, and after 2-3 days saying my insurance, I was very happy about that. It was made life more easier with having insurance.
The Kids Help is definitely an organization that you should look into. You should actually take a moment and sit back and think about how wonderful an organization like this would be to your community.
So Dr. Flores, I'll turn it over to you. Thank you.
Next slide, please. So just as background, oops, I think we
Went too far.
Yeah, can we go back to the first slide? Yep, there we go. Okay. So as was mentioned, 4.3 million US children, or 6%, are uninsured. In fact, every 42 seconds, an American baby is born uninsured. The proportion of uninsured US children increased by 10% over the most recent year for which data are available. And Kelly mentioned it's anywhere from 57% to some people estimate up to 90% of uninsured US children, so that would be 3.9 million, are eligible for but not enrolled in Medicaid or CHIP. And we know that major racial and ethnic disparities exist, so only 4% of white children. Oops, can you go back to the first slide, please? So only 4% of white children are uninsured versus 4% of Asian, 5% of African American, and 9% of Latino children. Next slide. Next slide, please. So, okay, it looks like we went out of order. So lacking health insurance is one of the worst risk factors for adverse child health outcomes. We know that uninsured children are significantly more likely than insured children to have worse health, no regular physician, delayed immunizations, unmet medical and prescription needs, and impaired specialty access, higher odds of emergency department visits, avoidable hospitalizations, injury hospitalizations, and adverse newborn outcomes, and even greater risk of dying in hospitals, intensive care units, and after trauma. Next slide. Yep. So as you just heard in our video clip, parent mentors eliminate children's healthcare disparities. So parent mentors, I'll refer to them as PMs, are a special category of community health workers for children in which parents who have children with a particular health condition or risk, such as being uninsured, leverage their relevant experience along with additional training to assist, counsel, and support other parents of children with the same health conditions or risks, navigate the healthcare system, and address social determinants of health. And 2 randomized controlled trials by our team have demonstrated, that PMs, if you could go back to the last slide, please, are highly efficacious and cost effective. Next slide. So we'll examine one of these, which is a randomized controlled trial of the effects of parent mentors on ensuring uninsured minority children. Get more information on the articles in Pediatrics and Health Affairs and at the website. Next slide. So just an overview of the study. So there were 237 uninsured Medicaid and CHIP eligible Latino and African American children who were recruited at 97 community sites in Texas. As you know, that's the state with the most uninsured children in the US. And they were randomized to PMs, or the control group, which consisted of the usual Texas outreach and enrollment. And PMs were minority children in the primary care clinic who already had at least one Medicaid or CHIP covered child who had coverage for at least 1 year. And the PMs underwent a 2-day training session. Next slide. So the results were as follows in terms of obtaining health insurance coverage. A significantly higher proportion of the PM group obtained health insurance versus the control group at 95% versus 68%, which was highly statistically significant. And the PM group had significantly higher adjusted relative risk, over 1.3, and odds of triple the odds. Back, please. I think you have me on auto timing, so if you could just turn off the auto timing, we won't have to keep going back and forth on the slides. All right, next slide. So this slide shows time to coverage, renewal rates, and long-term coverage. The first column is the outcome, second and third columns, the means and proportions, the controls and PM group. The final column is the p-value. All these are statistically significant comparisons. You can see that the median number of days obtaining insurance was 140 for controls, only 62 for the PMs. Renewed insurance, 60% versus 85%. The 2-year coverage rate, 76 versus 95%. And the 3-year coverage rate was 76 versus 100%. Next slide. This slide shows healthcare access and out-of-pocket costs of care, and you can see that the control group was much more likely at 39% to have no primary care provider versus 15% of PMs. No usual source of preventive care, it was 7 versus 1%. Never or sometimes gets immediate care from a PCP, 19 versus 0%. Problems getting health care from specialists, 46 versus 11%. Unmet healthcare needs, 25 versus 13%. Unmet dental care needs, 31 versus 18%. And you can see that the mean out-of-pocket costs for doctor visits and for sick visits were much higher at $37 versus $33 and $43 versus $9. Next slide. In terms of satisfaction with care, quality, and family financial burden, you can see that the controls were much less likely to report being very satisfied at 25 versus 57%, but much more likely to report being very dissatisfied at 21 versus 6%. 16% of controls wouldn't recommend their child's healthcare provider to friends, 6% in the PM group. The doctor never sometimes respects your expert on your child, 23 versus 11%. The actual overall quality score on a 0 to 10, where 10 is the best, was lower in controls versus the PM group, 8.6 versus 8.9, and need additional income to cover the child's medical expenses, 13 versus 6%. Next slide. We went one too far, one back. In terms of cost and cost effectiveness, the PM costs were reasonable at about $637 per year, but the PM savings were over $6,000 per insured child per year. That's a return on investment of 850%, so $8.50 saved for every dollar spent. Next slide. So we concluded from this study that PMs are significantly more effective than traditional Medicaid and CHIP outreach enrollment in insuring uninsured minority children, getting the insurance faster, renewing the coverage, improving access to medical and dental care, reducing unmet needs and out-of-pocket costs, achieving parental satisfaction and quality of care, and teaching parents to maintain the children's coverage up to 2 years after intervention cessation. As we mentioned, PMs are relatively inexpensive at about $636 per child per year, but highly cost effective, saving over $6,000 per child insured per year. Next slide. Implications include, given that up to 3.9 million US children were uninsured and Medicaid and CHIP eligible, and 53% are Latino or African American, the findings suggest implementing PMs nationally for minority children could save over $12.3 billion. If the PM intervention is shown to be effective for all racial and ethnic groups, the findings suggest implementing PMs nationally for all uninsured children could save almost $22 billion. And PMs and analogous peer mentors for adults could prove to be highly cost-effective interventions for eliminating disparities and ensuring all Americans. Next slide. And we had a nice translation into policy. So based on our work, federal CHIP reauthorization legislation signed into law in January 2018 makes organizations that use PMs eligible to receive $120 million in grants for CHIP outreach and enrollment. And all 50 states and DC can now apply for CMS funds to implement the successful evidence-based Kids Health PM model, and community-based organizations in 7 states already have received funds. Next slide. So I want to finish with some urgent policy priorities, and this echoes what Kelly was mentioning. So full, uninterrupted federal funding should be secured for Medicaid and CHIP. Since CHIP's inception in 1997, Medicaid and CHIP together have resulted in a 47% reduction in uninsured US children. Now it's 6%. In contrast, 12% of adults are uninsured. CHIP should be made permanent and CHIP coverage extended to 300% of the poverty threshold for all US children, as Massachusetts did, cutting the childhood uninsurance rate to less than 1%. Next slide. Every child should have health insurance, including the undocumented. First, it's the right thing to do. Second, it ensures that all children grow up healthy and maximize their potential. Third, not doing so comes at huge societal costs in terms of deferred care resulting in preventable ED visits, hospitalizations, injuries, and death. And as an example, we regularly have undocumented children with kidney disease that we see in our clinics, and they end up having renal failure, and they can't get subspecialty, so they have to go to emergency departments to get dialyzed at a cost of tens of thousands of dollars more than it would have been spent if they had had subspecialty care and been dialyzed as outpatients. Next slide. And finally, federal and state funding should be committed to implementing evidence-based programs, including PMs and community health workers, that are highly effective in Medicaid CHIP enrollment of uninsured children, given that up to 90% of uninsured children, almost 4 million, are eligible for but not covered by Medicaid and CHIP. And legislation could fund PM programs for all U.S. children nationally or at the state Medicaid CHIP and program level. Thank you.
Thank you so much, Dr. Flores. We really appreciate all that information about the Parent Mentor Program and its effectiveness, and proposed solutions on how we can move forward. And so, with that, I'd like to go to Dr. Rubin and get his thoughts as well. Thanks, Dr. Rubin.
Hi, everyone. Thanks for having me, to the team at First Focus. And it's great to join my colleagues here to talk about issues of health insurance coverage and not be talking about COVID, although COVID certainly magnified our issues with regards to health insurance and families. I first want to start out with my comments today are not meant to be an either or. I believe Kelly, really articulated a very clear vision for what should be done for children, issues that could be very seamless for families in terms of accessing healthcare for their kids, in terms of universal Medicaid to age 6, addressing issues of citizenship and access to health insurance coverage, extending continuous eligibility, extending income eligibility limits. All those things are really important. We've been talking about a lot of those things for a long time, but I've never heard them so articulated so clearly. But I also wonder a bit about whether we're not paying attention to something to a potential emerging crisis on the employer-sponsored coverage front as well too, which is the issue of affordability. What makes Medicaid and CHIP so popular is because it largely has a benefit structure that provides comprehensive care to children with low out-of-pocket costs to families. When you move into the employer-sponsored market, you'll see that that's not necessarily the case. And it struck me in Kelly's slides that about a third of those who are uninsured are folks who are uninsured because of income eligibility. While there might be some really wealthy families in there, our data from the middle of last decade suggested that people in the income brackets between 200% and 300% of poverty level who may not be able to afford their coverage through work are largely overrepresented among those who are uninsured due to income eligibility. But if we go, I only have 2 slides, and then I'll make my points about things we need to also be discussing in the employer-sponsored coverage market if we're to address issues of affordability, because I think we have to kind of concede that providing every child a health insurance card that's not affordable is not access to care. And I have numerous stories from my own experience as a pediatrician of families who were employed in small businesses, were in that income range of $40,000 to $60,000 a year with 4 kids, who did not take their child with congenital heart disease to the specialist, and the mother was afraid to acknowledge to me it was because she couldn't afford the visit. And we have to make sure we start addressing areas of affordability, because I think it's the most quickly emerging challenge. Now, first, is to say, look, to Kelly's earlier points, the popularity of these programs and the scale of these programs is being borne out by just how much participation there is. I mean, when people say we can't get to universal coverage in kids, well, we're up to nearly 40% and probably growing in terms of access to public programs. To get beyond that is not as measurable an increase as it might be, let's say, in some adult populations. And we've seen employer participation in healthcare drop below 50% now in terms of dependent coverage. And if I go to my next slide, why is that? All right. Well, the cost of family coverage has become prohibitive for many families. It's surpassed now $20,000 in terms of the between premiums and co-insurance and deductibles. And if the cost of family insurance through those high deductible plans that we've gotten so used to dealing with is reaching $15,000, $20,000 for a family of 4 or 5 individuals, well, who can afford that? Can someone who's, maybe someone who's making $100,000 or $200,000, but can someone who's making $40,000 or $60,000 in that income bracket that we're talking about, can they truly afford to put, that money needs to be on the table for schools, for other issues inside the family. And so, the comments that our team has been putting out there for the last few years is we have to start turning our attention, even as we advocate for the seamless solutions that are extremely important, to providing greater access for working families to affordable health coverage that's comprehensive. And what do I mean by that? Well, number one, raising income eligibility requirements and setting a proper floor for CHIP benefits, even as we embrace the long-term commitment to CHIP, is extremely important, because it would allow more of those families to make that decision to send their children over to Medicaid or CHIP. And particularly in states that currently do not reach income thresholds that would allow those families to participate. So they just decline coverage and take the premium savings back to their family. The second thing, I think it was something barely noticed in the CHIP reauthorization in the late 2000s, in that decade, was the potential availability of starting to explore buy-ins into CHIP. And individual buy-ins, not a lot of folks talk about individual buy-ins. They were fraught with complete bureaucracy, individual risk pools, and lots of challenges around what we call adverse selection. The sickest families with the sickest children would move over, and so it actually, from a cost perspective, the numbers didn't work. But what would it look like, for example, to start to explore employers buying into CHIP, where it's not where we get participation from the employed community to allow children who are in small businesses or other businesses to move en masse without adverse selection, likely a healthier risk pool, to move over into CHIP, into the same risk pool, so that all children benefit. We have a saying in pediatrics, 80% of the kids are healthy. It makes for really great risk pools. And if you start to allow a better employer buy-in, we can get those public numbers up in terms of public coverage and make it easier to make this transition to a more seamless plan. And so, look, if you told me today we can get universal Medicaid from 0 to 6, I'd say I'm in. But we haven't seen it. And so do we wait? Or do we start to take moves that would allow more people to participate in the generous benefits, comprehensive benefits, and the affordable coverage that Medicaid and CHIP allow? And so those are my comments today, and I look forward to Q&A.
Thank you so much, Dr. Rubin. I really appreciate your comments and thoughts, and as always. And now we turn it to our fourth speaker, Dr. White. So welcome, Dr. White, and thank you for being with us today. We appreciate you joining us.
Great. Thank you so much, Bruce, and thank you to First Focus for putting the panel together, and thank you to my fellow colleagues on the panel. Once again, I'm Marcy White. I am the Chief Medical Officer at Total Healthcare, which is a federally qualified health center based out of Baltimore, Maryland. Next slide. But I think most important, and probably as many of my colleagues and panelists can say, my most important role is as a mother of two, a 13-year-old and a 3-year-old. And I treat my patients and want for my patients the same that I want for my own individual kids. And so I think it's important, as we look at how policy affects certain demographics and populations, that we always have a North Star in regards to what we want for our own families, whether that be our own parents, our own children, nieces and nephews. You can't go wrong with those decisions, because you always make good decisions for your own families. And so we need to make sure we keep those in mind for those that we care for. So as a federally qualified health center, we are We exist to care for those in most need. We provide comprehensive care. There are 4 key components to the service delivery of federal profit health centers or community health centers. One that is being located in areas of most need, providing comprehensive services, so behavioral health services, medical services, dental vision. But I think most important is enabling services. So as Kelly mentioned in her presentation, the outreach and enrollment around insurance, having community health workers that can identify those individuals that need assistance with the social determinants of health, because we know that those issues impact health and well-being more so than anything. We are open to everyone, regardless of their ability to pay, regardless of their insurance status. However, we also know that insurance is a tremendous part of getting people to walk through our doors. And we also have patient minority governing board. So those are 4 unique issues for community health centers. Those would make us unique to serve the unique needs of the communities that we are in. Next slide, please. As far as community health centers, we serve 1 in 11 people in the United States and 1 in 8 children in the U.S. 1 in 3 of the persons that we serve are in poverty, and 1 in 5 being Medicaid beneficiaries. Next slide, please. For health centers, as far as the population, we have an advantage of being able to serve those from birth to old age, and so that makes us unique in being able to provide aspects of care across the continuum of the life cycle. But you can see here that 31% the individuals that we serve are under 18. And so what we're talking about here as far as covering all children and creating a path forward, I think this slide really highlights that, because we as pediatricians know that it is important to role model behaviors very early on. Pediatrics is focused on prevention, and as Dr. Rubin said, 80% of kids are healthy, but we have to exist for if and when they might get into older years where they need additional assistance or services. But it's important for us to be able to provide access to care, access to insurance very early on, because if we can get individuals to come into the health centers, to come into primary care centers to receive care and start to role model those healthy behaviors, we can continue to care for them throughout their lifetime. And currently we're serving about 31% of those under 18. So a huge opportunity for us to sort of set that path forward. Next slide, please. You can see here that 48% Medicaid, about 23% uninsured. At Total Healthcare in 2020, we had 27,000 unique patients. About 7,000 of those patients that we served were children under the age of 18. 4%, approximately 4%, so consistent with the statistics that were given earlier by Kelly and Bruce, are uninsured in our less than 18 years population. And then about 66% of our population was Medicaid. Next slide, please. So I think it's really important, and you've heard my colleagues on the panel mention, community health centers, we're only one piece of that access puzzle. We are considered to be the safety net providers that individuals go to and access care when there are gaps in insurance or gaps in coverage. However, what we want to do is to complete the puzzle. We don't want there to be gaps, because you've heard from my colleagues that when there are gaps in care, there is increased severity of illness. Therefore, community health centers, our population of individuals that we serve have much more advanced disease. They're much sicker in regards to their diabetes, their hypertension. And we know that it's important for us to provide access to care, and access being not only the facilities and the ability to receive services in a location, but also access to care as far as that insurance card. We know that individuals that do not have insurance and or gaps in care, the delayed immunizations and the impact that that can have on a public health standpoint. And so ensuring that that insurance card is something that we do provide continuously as far as access to insurance, so that there are not any gaps. As Dr. Rubin said, we can give many examples of patients that we have seen and taken care of that unfortunately have presented into our health centers with very advanced disease. Many of you on the call, or your children, or you yourselves, may have had an ear infection. I recall having a young girl years ago that had an ear infection, and she was not seen by the primary care providers because she lacked insurance. And by the time she presented to us, she had an infection of her mastoid bone, so mastoiditis, which is a very serious infection that can then lead to a brain abscess. And so, you know, in the United States of America, in this century, for us to have an ear infection, understanding we have immunizations that prevent ear infections, we have antibiotics that can treat ear infections. To have an infection, to a really acute infection, to go chronic and cause that level of severity is just unacceptable. And that patient did not present due to the fact of having a lack of insurance. And so we need to make sure that this puzzle no longer has any gaps, that insurance access is continuous, so that we can really make sure that people are establishing healthy behaviors, understanding that they can come to individuals to receive the care that they need, that community health centers can be sustainable, because although we see individuals, regardless of their ability to pay, we still rely on other funding streams to help subsidize and support that. And so having access allows that sustainability for community health centers as well, and also makes it much easier and seamless for the families that we serve, understanding the complex lives that they may live. But I think one of the main issues in regarding access and insurance is that healthcare providers not only give prescriptions and treat the immediate effect infections and or provide prevention. What we also do is we also look for the social determinants of health, right? We screen for those other issues that families may be dealing with that then might cause additional burden or cause additional health disparities. And so looking at transportation, leveraging those community health workers to identify those other needs. And so having that insurance card provides a much more holistic approach to health and well-being. And I think it's important for us, when we think about healthcare access, we're thinking about all those additional components, because yes, we will provide the prescriptions, we will provide the immunizations and do the preventive medicines, but we're also linking into food pantries, we're signing up for insurance, we're also looking at housing needs as well. And so looking at the whole person when we're providing them that access to care. So let's make sure that this puzzle here on this graphic has no more gaps, and that we can provide continuous access to children in the United States of America.
Thank you so much, Dr. White. That was awesome. And thank you all the panelists for an excellent overview of all the issues. I think that you all touched on a very important things such as prevention, public health, the need for better outreach and the importance of that for the eligible but uninsured. Issues of coverage, the various options that are important, including Medicaid CHIP, but also employer coverage and the Affordable Care Act, access to care issues, community engagement, the role of parents, all those things. So I really appreciate that. Why don't we go to the questions, and Kelly, I think I'll turn the first question to you. Joel Ryan, our friend Joel, asked the question, what changes are included in the Build Back Better package, and are there states that have 24-month authorizations?
There are lots of things in the Build Back Better package that we've been tracking and monitoring. We've mentioned the importance of making CHIP funding permanent. That's included. Another top priority is 12-month continuous eligibility for children. That is included as a requirement for Medicaid and CHIP. So that would be impacting about half of states that don't have that option today. As far as states going for longer than 12 months, there are a good handful of states interested in multi-year continuous coverage, but none that have been approved that I'm aware of. But I know that California, Oregon, Washington, and others are actively exploring continuous eligibility provisions that would go in some cases 0 to 3, in other cases 0 to 5.
Thank you. One thing that I would like to ask all of you. I know we don't have a ton of time, but I think one of the issues that we're hearing a lot about right now is sort of mental health issues for kids. And so, can you all talk about the importance of coverage and access to care to address mental health care, and are there unique issues that we should consider? So, why don't we go first to Dr. Rubin, then Dr. Flores and Dr. White, and Kelly, if you have any other thoughts.
I think one of the things that makes public insurance so attractive, particularly CHIP and and Medicaid for sure, but CHIP in general has had pretty comprehensive benefits. It includes mental health benefits. Even the ACA plans have a history of not being necessarily inclusive in terms of some of the plans that are offered in terms of pediatric benefits. And so clearly, one of the critical needs right now in the country is access to affordable behavioral health care. Now, that coverage alone simply is not going to solve issues that are much more challenging and relate to workforce participation and broad funding for a variety of different interdisciplinary professionals that work in mental health. But that said, is to recognize that right now the strongest plans that are available are these public plans in Medicaid and CHIP in terms of access to behavioral health benefits. And that needs to change. And it's one of the reasons why I think between Medicaid and CHIP, we have a template here to kind of provide the comprehensive benefits package that should be required for all health insurance packages for children.
Dr. Flores, anything you want to add to that, or Dr. White?
Yeah, Bruce, I'm glad you brought that up because we're facing a mental health crisis in kids right now, particularly with COVID. The rates are only going up, not down. And pre-COVID, we know that a child presented to the ED for a physical complaint, if they were screened, anywhere from 40 to 50% of them would actually have an undiagnosed mental health issue. Clearly, if you're uninsured, you're already at a disadvantage because you won't get early diagnosis. You're unlikely to get early treatment. And so that's a huge issue. But even more concerning is even if you get Medicaid coverage, I mean, we see it in our community. I'm sure the other pediatricians see it in their community, having access to mental health care providers who actually accept Medicaid or even CHIP is extremely difficult. So it's a broken system. It's probably a whole nother webinar, but it's sort of a double strike against those who are uninsured because we know this is a fact. They don't get diagnosed early, they don't get treatment early. And if you're minority, I mean, there are studies that show that actually it's out of Dr. Rubin's institution that if you're African American, you're much less likely to get diagnosed early on with ADHD and with autism, and you're much more likely to get treated late and not by a specialist. So it's really a huge disadvantage if you're also minority and uninsured.
Yeah, I would agree with Drs. Flores and Rubin, and the access piece really around those providers, available once we can screen and identify individuals, having those providers available to provide the care. And so I think it goes back to one of Kelly's points in regards to the partnerships with the trusted community organizations, being primarily the schools, to be able to really fill the gap in trying to provide that access.
Can I make one other comment there, Bruce? I think that was a terrific comment there, which is, I think we learned through the pandemic, and this is where I get to say something about the pandemic, but we learned through the pandemic just how important school-based health solutions are. And I think we have to reimagine, given workforce challenges we have in behavioral health, and Glenn is right, we probably need a whole other webinar just for this issue, is to recognize how to strengthen school-based health programs and get more brief interventions and group interventions into schools with proper reimbursement to support that, because it's easiest for kids to access some of these services during the school day.
Kelly, do you have any other thoughts on that, on mental health, school-based health?
No, nothing to add, but I agree with the remarks from all the other speakers.
Excellent. So on that, I'll ask this question and one other, and I know we're at the top of the hour, but I definitely want to follow up on that. I would love for you guys to talk sort of about both ends of the spectrum, so sort of the littlest kids and then also adolescents. And so what are some of the kind of the unique health issues that sort of, we talk about how in the kid space that kids are not little adults, but even within kids, there's very unique needs even around different age groups. So, I know that's taken on another webinar too. You could talk about both those issues in that, but could you talk a little bit about some of those unique differences and issues that we should address and think about for those two populations? I'll go to Dr. White first. I'm sorry.
No worries. No, I certainly feel for the adolescents, mental health, really being key, just even developmentally what they're going through during those periods of time. But certainly early literacy, food insecurity, just nutrition, overall nutrition, wellness. We've also seen due to the pandemic, immunization, decline in immunizations. And so one of the things we certainly don't want to overlay on top of COVID pandemic is another pandemic of preventable illness that we've had a history of eliminating in this country. And so, early school readiness, immunization, mental health, as well, and then truly dealing with food insecurity. I think that was also highlighted in the pandemic in regards to the need to have the schools continue to provide food, and then other institutions such as the faith-based community stepping up and having food pantries and distributions as well. And so, certainly we know that nutrition is essential, and definitely we've made a lot of headway with immunization and public health outside of COVID vaccination, but with our other food-based immunizations as well.
Dr. Rubin, do you have any?
Yeah, I want to say one of the great benefits of splitting pediatric versus adult coverage is it's created, I think, a lot of groups, particularly in Medicaid and CHIP, but these who think about children and think about from infancy all the way up to adolescence the services they need. It's why, if you look at CHIP didn't require a benefits package, but when the states came together and brought their child experts together, most states developed pretty broad, comprehensive benefits. I wish our employer-sponsored plans would be pegged at the very minimum to their state CHIP plans, right? Or given the amount of thought. And I can't tell you in conversations, this goes well beyond what services you offer. When children get lost in adult discussions about universal coverage, you end up and quality. You end up with having to measure cholesterol levels in children or being accountable for them when it's highly irrelevant to most of what we define as wellness in children. Anyone who practices pediatrics or family medicine is familiar with that dance, and it's why I think even if we were to make the dance as a country towards universal coverage for all folks in the country, there's a value to keeping the kid stuff separate and dependent coverage separate. It's a little clunkier, but it results in better, more thoughtful, comprehensive benefit packages for children.
That's awesome. Dr. Flores?
Yeah, so it's a national embarrassment that every 42 seconds a child is born without health insurance. And so why is that? Well, we've done focus groups, and it's shocking to hear parents tell us they don't know about the programs. They usually don't understand the income eligibility. They usually think it's like $5,000 a year, so they sort of rule themselves out. There are all kinds of hassles, in particular in states that I've lived in before, like as Bruce knows, Texas, where they intentionally make it difficult. And with a 6-month renewal, you basically have to bring in a stack of paperwork. So it's just not a system that's friendly to insuring young children. And then, of course, pile on the public charge issues that are still lingering, where particularly in mixed immigrant families, a lot of the parents just assume that enrolling their kid in Medicaid and CHIP, even if they're eligible and born here, would be a huge strike against them. At the other age spectrum end, we're dealing with adolescents who don't have access to subspecialty care that they need, particularly children with special health care needs. And then we haven't talked about this, but transition care is huge. If you're a child with diabetes or asthma or any kind of subspecialty need, and you turn 18, and then boom, you have to find an adult provider who will cover you, you're usually out of luck. And so we really need to start thinking about that and how we have a seamless transition for kids who have chronic illnesses.
Excellent. Kelly?
Only thing I would add to this question is that in terms of coverage rates and differences that you see by age, we actually do a better job of covering younger children than we do of covering school-age children and teens. And we have seen increases in the uninsured rate for the youngest kids that are very alarming. Of course, those kids need to be seen very frequently to make sure their development is on track. But historically, it's the older school-age kids and teens that are more likely to be uninsured, and for all the reasons that the other panelists have mentioned, that can be really concerning, especially for their mental health.
So with Congress poised to act on some of these proposed solutions, I'm sure all of us are hopeful that Congress will take positive steps forward to reduce the number of uninsured children in our country, and some of those provisions that we talked about in the Build Back Better package. Before we close, I just want to thank on behalf of the First Focus and all of you today for appearing. And I'm going to come back to you for one, final words. And I also want to thank Congresswoman Castor for hosting today's briefing. And thank each of our, and also thank our funders, again, the Robert Johnson Foundation and the David and Lucille Packard Foundation. First Focus will continue to fight with you all until our nation's children have access to, all of them have high quality and affordable care. So last, I just want to ask you all for one final, last words. Any thoughts that you would like to leave with people? So I'll go in reverse order. Dr. White.
I'm going to piggyback on something that Dr. Flores mentioned earlier in his presentation. Coverage for kids, continuous coverage for kids is the right thing to do. We have no excuse. Certainly, it's something that we can and have the ability to do if we just come together and make it happen. It's something that I want for my own kids, and so I want for all of American children. So let's do it.
Excellent. Dr. Rubin.
Throughout my time that I've spent time around children's coverage, I always think about the history of the Medicaid program and where it started. It started because of a concern about the health of adolescents and young adults who are going to the military, and the health of our children. And as we come out of the COVID pandemic and we're looking at sort of, escalating mental health crisis that wasn't caused by COVID, but was exacerbated. It was a growing trend. Issues related to obesity and that have only been made worse by the pandemic, and overall health of our children. It strikes me that this is a really important inflection point to recognize the value of affordable health coverage for children and the importance as a national goal for all families in the United States. And so, I hope and applaud those who are taking constructive steps to increase access to care, access to affordable coverage, sort of cementing the foundation of children's coverage for years to come, and would only encourage you to move further.
Thank you. Dr. Flores.
Well, the facts are indisputable. Lacking health insurance as a child is one of the worst risk factors for adverse outcomes. And yet our nation's heading in the wrong direction, as we all put focus on. And so, for anything else, if our children were ending up being unimmunized, if they were going to the ED more, if they were getting injured more, if they were dying more, it would be a national alarm, and it's not. And so we have millions of children who really are desperate for a solution, a policy solution that will ensure that every kid in the United States has health insurance. It should be one of the most important policy priorities we have in our nation.
And last word for you, Kelly. Any last thoughts for us?
Sure. I'll just leave everybody with a sense of optimism and say that, this is a problem. We've been going in the wrong direction for the last several years, but we know how to solve it. And with the strategies discussed on today's webinar, we know how to get to a place where all children have access to affordable, comprehensive coverage. We know the steps that need to be taken. We just need that bold leadership. So, we're primed, I think, to do the right thing and reverse some of the trends of the last few years, and hopefully go even further to where we can reach 100% of children covered.
Thank you all so much. I have, as you all know, I have enormous respect for all of you, and I really thank you all for joining us today and really sort of setting us a great direction back on toward of getting all kids covered and that path that we must take. There's there's definitely a lot of things that you all brought to the table that I think if we adopted, we would get there. So thank you all very much. And thanks everyone for joining us today, and have a great afternoon.